everyone.
Hello. We were having so much fun watching all the comments and where everybody's from. We had to jump in early so we could say hi because you guys are posting so fast we can't keep up.
She was trying to type it real quick. I said, "Oh, we'll just start a little bit early, kibitz, till we hit the 8 o'clock top of the hour mark." So, how's everyone doing? Where are you visiting from? We had over 1,200 people register, so this is going to be a hopping meeting tonight.
Yeah, and we like it when you comment in the chats. We can both see them,
Mhm.
and so that's a lot of fun to be able to see your feedback as well as comments that maybe some of you guys have gotten some insights on the changes that will help us illuminate and unpack some of the things that we're going to talk about tonight. So share your insight as we go along.
Yeah, we've got we're simulcasting like, oh my goodness, everywhere. We are on YouTube, Facebook, LinkedIn, and that's for CCO. And then Find a Code is doing this with us, and we're on all their channels as well. And of course, StreamYard. So everyone who's here for the CEU is coming into the StreamYard venue. So
I thought Wasilla, Alaska was the farthest, and then I saw the South Africa post, and I was telling Lori, I said, "Do you remember when that group that used to come up from South Africa to the regional or the national conferences every year?" Yes, and now someone just posted from Puerto Rico. So I don't know if Puerto Rico's got to be closer than South Africa, where even if you're at the northern part of South Africa. So a lot of fun.
see, my friend Grace Maid is here. Welcome. Thanks.
That's right.
So we got Alicia's going to be driving the slides tonight. I'm going to be her little Vanna White. We gave Jesus and Boyd off for the night. I said this StreamYard sure does make it easy that we're able to do that. So hopefully we won't hit too many glitches.
And if we do, we know you guys bear with us. So you give us a lot of grace and we appreciate that. And you know what? I think that's what a lot of people appreciate about us, Laureen, is that we're we're somewhat casual. And besides the passion that comes through, I know, everybody knows we love what we do. But I can tell. I've seen lots of LinkedIn people. I was commenting earlier to Lorraine. I said, I don't see any LinkedIn people. But as soon as she hit the button, they started popping through. So good to see them. If you guys are,
I was going to say, with the StreamYard, we can see everyone's comments from all the different streams all in one. So we're seeing everything. It's kind of going really fast right now because everyone's coming in. So that's good. No, you do not need to put your credentials in the chat. At the end, you'll be given a password to go take that one question quiz, and you'll get your certificate that you can print from there. So the proof is that you're coming in. We have a whole registration page of everyone that registered. And then it also tells us everyone who attended and stayed to the end. So that's the proof that we use with the certifying agencies that, if they audited and wanted to know. So you don't have to put your ID in there. And we'll give that at the end. And I think it's 8 o'clock. So I'm going to play the intro one more time and then we will get started. Let me see if I can find that.
Oh my, one of the Village MD people.
I played it once. I know it's in here.
Katrina, so glad to see you here. These are posting so fast.
I know.
Oh my, this eyes.
Here it is. Okay, I'm going to do the intro and then we'll get started officially. All right, welcome to CCO and Find a Code. We're doing a joint presentation on the 2025 CPT updates. And I'm Laureen, your host, and we have Alicia Scott, our senior instructor, that's going to take us through the changes for CPT. It's not too bad, not too scary. So did you want to bring up your slides to start?
Are you not seeing them?
No, you have to. Oh, I know what I need to do. Hang on.
There you go.
I wasn't being a good Vanna White.
We just talked about how we were planning that. You guys, it is a really interesting year for CPT as we highlight some of the updates that are going to be implemented on January 1st. I think you're going to see a trend. The technology component got a lot of love for 2025, which makes sense. And we wanted to tell you that one of our goals with this presentation is to educate you because, as you know, CCO is all about education. That's what we do full time, and we're really, really good at it. If I do say so myself, giving myself a pat on the back and a virtual for Laureen. Now, because of that, as we go through this presentation, the highlights, we're going to kind of preview some of the highlights that are pertinent to everyday coding. There's a lot of changes that for most of us aren't going to be very applicable to us in the mainstream coding world. We'll show you those. But the main purpose of tonight is to give you some insight as to what's happening for January 1st, but also to show you how to also look at these code updates on your own. It's the whole premise of, I can give you a fish or I can teach you how to fish. That's the goal. And ultimately, how many of us through the years have gotten so bored watching the updates, and it's almost like a drone where they say, 71224, da da da. That's not what we're doing here. We're going to also talk just a little bit as we go through and look at some of these codes, what the behind the scenes is, why we think that maybe this code was implemented or changed or updated, so on and so forth. So again, that's the purpose. We're not going to actually look at every single little code and talk about them because they are kind of grouped in themes. And hopefully this will educate you as well on how do you pursue the following year, how to see the updates. Especially if maybe you have to present the updates yourself. Before we jump in, we got to do a little commercial and tell you about the CEUs and the drawing that we have every time that we do one of these monthly presentations. Many of you guys have been with us for a very long time. You know that Laureen started the bat technique way back in 99, right? So she's been doing this a long time.
We're old.
Not to age her or anything, but just telling you that again, a lot of you guys have been with us for a very, very long time. And that being said, you know that we like to promote education and we like to give things away. And in the past, we did our monthly webinars. Then we got to where we were punching out like 2 or 3 a week. And now we're moving back to that monthly webinar format again, because that's what the people spoke and said that that's what they appreciated the most: larger segments, bulkier information. So at the end of the presentation tonight, you're going to be able to get your one free webinar CEU. And we we're told you already that you have to be live to attend, and there'll be a password, and we'll walk you through that at the end. But we do want you to stick to the end because we're going to give away some freebies, and we'll talk about those more.
And that said that it was going to expire after an hour. It'll be up like past midnight, so you'll have plenty of time. And last time, so many people were hitting the server to get on that it got jammed up. So if that happens again, just wait 24 hours till tomorrow. You'll get the email that everything's set for you to go in and claim your CEU. So just do it tomorrow morning when you get up. And it only takes a few minutes, and it'll be a nice printable, certificate for you.
And we'll also be able to tell if you were here from the beginning to the end, because we'll be able to see those people that said, how come this isn't coming through? Or I need to do that, or did it, because Lorraine's already told you. Just be patient. And I think even before we closed out, people were saying, hey, it's done. It's coming through. So
They
again,
started to get it. Yeah.
yeah, it's just a little slow because there's so many of you guys. So awesome. That's great. Let's do a quick, brief little history. We probably have some people here that are new to the code sets, and therefore I wanted to remind you that the latest updates to the CPT code sets, which is the procedures, what we do to patients, that code set reflect the advancements this year in contemporary clinical practice. You're going to see some highlights there, and to ensure the code set fulfills its vital role as the trusted universal language of medicine. And again, as we look at some of these codes, it's going to make sense. What's new? Well, we have 270 new codes. We have 38 revised or changed codes and 112 deleted codes. Our focus is going to be on the new codes. Why? Because everything revolves around the new codes. If you were with our ICD update, remember that I told you that you can pretty much see everything that happened with the diagnoses based on the new codes. And when new codes are implemented, then old codes are, as they're expanded, more or less, that shorter version of the code is dropped. Well, that doesn't really happen with CPT in the same way. However, it's similar, right? Some of the reasons for the new codes is because we have codes that are baby codes that become full-grown adult codes. And that being said, our main focus is 270. Now, I'll mention this again later, but the revised and changed, probably 97.2% of that is grammatical. Okay, so they added one word.
97.2%. That's pretty specific.
Yeah, I just thought that would make them remember.
It got
And of
my
course,
attention.
that's me estimating, how. So again, it's just adding. I think, Lorraine, when we were talking about it, it's like, okay, they just added an A, or one word. So it's pretty much
Yeah, there was a lot where
grammatical.
it's just a semicolon because I was doing
Oh,
that
that's right.
for my day job, and I'm like, where is the difference? And I'm like, oh, it's a semicolon.
Now, there are which we'll show you here in a minute, but just a little heads up. Some of it was just a revision of the sentence. Just again, they just put the noun in a different place than I mean, it was just kind of odd. It made you stop and pause and think. All right, so again, that's the basis of what we're going to talk about tonight. Now you've had that heads up. Overall, 420 updates in the CPT 2025 code set. The meat of it always is the new codes, and that's what you're interested in. And the new codes, there are trends every year on what
Mhm.
is going to be focused on. So see if you don't recognize some of these trends. Now, looking at the codes via an encoder, that's going to give you the information of the changes. We're going to highlight some specifics, things that you need to have brought to your attention, but we're actually going to go out to find a code.
Yeah.
And therefore, we want to show you how easy it is to find the stuff in Find a Code. Find a Code is my full-time encoder. And so I resonated with it early on, and I think Lorraine will back me up on this. One of the reasons we like Find a Code so much is, again, it's education driven. The people that develop it also are into education, and they also listen when you
Yeah,
tell
very
them, hey, we
responsive to our requests.
extremely, hey, it would be easier if we did, if you did XYZ because this is what I do. Man, now I have to tell you, they implemented some of those change incredibly fast, and other times they think about it and stuff. But that means that they listen to you. And
Mhm.
some of these great big giant encoders, you're just a peon. They're not necessarily going to listen to you. But Find a Code, very responsive. So again, we use Find a Code at CCO. I know I use it full time with the anything else that I work on outside of CCO, excuse me. And therefore, I want to show you the process that I use. No need to pay for education of the change codes. Again, when they have webinars every year, they usually throw out, hey, join this webinar, pay X
Mhm.
amount and see the new changes. For one thing, there's no need to ever do that if you have find a code. Also, because it's at your fingertips anyway, and I'll even show you how you can see all the previous years. Now, if you're reading this again, it's that time of year for change. It never gets boring when you have a job like ours. Let's take a moment now to think about what are some of the main highlights of the changes. The CPT code set, I know, again, it expands in specific areas every year. So again, if you're not sure how that works, they get to, the powers that be within CPT AMA, they think about, we've got all of these things that need to be implemented and upgraded and changed in the code set. We can't do everything at once. So these are our priorities this year. These are our focus. So they take out a few things. Think of it like when you get a flu shot. Every year there's like 4 components or to a flu shot, and they say these are the big strands of flu that we predict that are going to be bad this year. So that year you get like four strands, and then the next year you get 4 different strands, and pretty soon you've got it all. That's the way they do that. They break it up in little particular areas. This is going to be really important going forward. Next year we need to give this a little love. So this year, new areas of medicine with proprietary laboratory analysis assigned to the largest portion of the new codes at 37%, mostly for novel genetic testing. Now, since I've said that, these are those O codes that most of us never touch. So we're going to show them to you, but I'm not going to sit there and spend a lot of time on them. Again, they're not something that most use in everyday coding. However, it did have some major updates. The Category 3 codes for emerging medical services account for a third of the new codes, 30%. Now, that is somewhat typical. It's maybe not always 30%, but every year, emerging medical services. That's why the code set has to be upgraded. And that's where we say those little baby codes, those uh, temporary type codes, they become adult codes. Now, that's not the right vernacular. Laureen can tell you what the right vernacular
No,
is.
we were talking about it the other day. I said I call
Yeah.
them the lady in waiting codes. So
Mhm.
they're being trialed, and if they're found to be well used codes, then they'll graduate and they'll become a level 1 code. So
Right, right. And that brought up the point that I said, do you think that some of them remember what the difference is between level 1, 2, and 3? And I was actually going to put it on the screen, and then I later decided not to. So level 1 codes or category 1 codes are the main bulk of what we see when you open up your CPT manual. Okay. Then level 2 codes or category 2 codes are what are
the PQRI or the MIPS.
MIPS, right?
Yeah,
Quality measures, right?
yes,
The quality measures that have to be tracked. And then 3 are those emerging codes. So,
temporary.
yep. So all of those new things, like remember when robotic surgery became a thing? If some of you guys have been around there, you have to give us a shout out. How many of you guys remember when that started? So they were doing like robot prostate cancer surgery or robotic this or that. And it was like, whoa, all these crazy, new codes. Well, that's out. And there's a lot of amazing new technology that has happened. And we're going to highlight those for you. Key updates. We're going to jump into the code set. So I'm going to bring over find a code. And I should be able to just do this real quick for you. This is what, oh, that didn't work. Hold on. That's because I'm sharing the presentation, not let me just stop sharing real quick. Oh, here. There we go. Now I can bring it over, I think. Nope, that didn't. Hold on. I apologize. I'm going to stop sharing for just a second.
You're okay.
Where is my sharing button? Oh, it's over here. Stop sharing and present. Share screen. And it's going to be that one. All right, let's try it again. Oh, didn't come over.
So if you just click on the plus, then a second tab and type in find a code, will that pull it up?
You are so smart. I think that'll work. It did. Oh, then you get to actually see how I log in and how some, well, actually it remembered me, so it's not. All right. Most encoders look similar, but what you're going to see is that after you've logged in, you're going to look at the code set and find a code. Now, you can save codes. You can, I spend a lot of time here in diagnosis coding and even in the ICD-11. But we're going to be looking at procedure codes. Now I go over here and just click on CPT. And it gives me the option I can search for a code. But what we're going to look at after we get in here, I can look up in index, modifiers, and all that other yummy good stuff. I'm going here. Now, before we click on the new codes for 2025, I want to bring to your attention, look right here, 2024 and past years. It goes way back. And that's pertinent because if you're working in an area where you have to go and say, wait, when did that change? Now, please don't think that that's something that you may have to go into very often, because if you even go into, say, I'm going to say A50.84, end stage heart failure. Let me just little tangent here real quick. This tells me that I am looking at the November 14th, 2024 version. I can actually go in here and change it. So if I need to say, wait, did that code, and that works with CPT as well. So that can be very important, but let's not go off on a tangent. Let's go ahead and go in our procedures, look at CPT, and look at the new codes. Here we're told 281 codes. See this first code right here? This is one of those genetic codes. When we're going to go through this pretty quickly, there is a lot of codes that start with an O. Now, I've got some highlights that we're going to talk about, and you'll say, yep, I remember she spoke about those.
Hey,
Again,
Lisa, I
yep.
just wanted to jump in here because this is something that came up for people that have jobs where they're kind of responsible for updating the new changes as they come out. What I like about what Find a Code's doing now, because they're bringing out new codes in between when the coding manuals are printed. So sometimes it gets a little confusing. Well, when did this code actually start? So if you look to the right, they have first appearance in the code book versus when the code was actually added. So these codes we're talking about as a 2025 update, technically they came out in July. So just keep that in mind. So if you see different numbers where other people are saying, oh, there was X amount of new codes, you know, this is what was officially in the coding manuals. But a lot of these, they had their birthday earlier.
Right. Yeah, that really good point.
And
And
if you click on one of them, Alicia, you can show them how they can see that. You might have to go to like an existing code, just type in a regular CPT code like 99212 or something. And if you scroll down, the way Find a Code has, they have these expandable trays, if you will. And if you go to the one where, let's see, where's it talk about?
what's your thought process? Mike, telling about the code history?
Yes, code history. That will let you know when its birthday was, when it hit the manual, and if it's a deleted code, when it was deleted. So that code history will give you that information if you need that. I know on my day job, I definitely need that. So.
And another thing about the code too, I've used this section also, where it jumps in and gives you more information about codes around that. But and again, now I am a person, Laureen can attest to this, I get lost frequently when
Keep it distracted.
okay, that sounds a lot better than in fact, before we started, I said, "Where's our slide deck again?" You know, and I'm thinking, "Where did we put that?" And she's thinking, "What? That's pretty important. Did you lose it?" You know. That being said, very user friendly. All right, now we can look at these codes a few at a time. I don't want to scroll so fast that it makes you dizzy. So if you get dizzy when that starts scrolling, you may have to shut your eyes for a second. One of the reasons that they do these genetic tests is because about every 5 years, new genetic discoveries are made. And one of the examples that I like to tell people in, why is this important? Because again, every 5 years, they'll discover uh, new things for a disease process. I use my son for an example, and he has an epilepsy that he was born with. He had seizures when he was born, and as the years progress, about every 5 years, they say, "Hey, it's time to do genetic testing again because they haven't found the cause of his seizures." And he's 20 now. So we had just done that. And so when these codes popped up, it clicked in my brain. Oh, that's right. It's that time of, every 5 years because new discoveries have been made. So they do the genetic testing and then we get a call back that says, hey, we didn't find anything bad and scary genetically that we discovered. And maybe someday genetically they will. We get, I get information from a particular professor at SUNY in New York, and he's always pulling out research that they found some enzyme in the gut that is going to be a game changer for a specific disease like Alzheimer's and stuff. So that's why it's important that we're aware of these particulars. And again, breast cancer, HPV. Again, the gut. They find a lot of really cool things in the digestive system. All right, so we're going to scroll through these pretty quickly. We've got a few that we'll highlight later, but let's get down to the more heavy hitters of what we may see get out of the zeros. Also, another thing that I really appreciate the finding code, it's alphanumeric. Okay, so again, with CPT, it starts with the numerals, and you can slide through here really fast. Now, you could also do a control F if you wanted to, but look. Remember when it said what percentage was these genetic codes?
Yeah.
That is a lot of codes. All right, here we go. All right. The first one, let's just highlight the first one. We'll use it to move forward. Notice 15011, harvest a skin for skin cell suspension autograft first, and then it has a size. Whenever there is any code that they add that is size and margin pertinent, that tells you that you're probably going to get 3 new codes because they usually do it in a sequence of 3 measurements. Not always, but predominantly a minimum of 3 in most things. Uh, that being said, when you harvest skin, that means you have to identify when you harvest something, where did it come from? Autograft is from the person. So whenever they do any type of harvesting, a lot of times they'll take it from the thigh, and they'll slice off that thin layer. But it's not just harvesting the skin. They've got to treat it after they harvest it to get it ready to prep to be placed on wherever they need to place it. A lot of times it's burns or grafts or whatever that they're doing. So there's several things that will make one code bulk out into many. Right here we have harvest of skin cell, suspension, autograft, and then we have size. And then you notice the sequence, same thing, the size, but each
Each additional.
additional 25. So that's an add-on code. Don't code it first. Now, we harvested. After we harvest, we've got to do a preparation, and then it repeats. We've got 1-3 and 1-4 additional. Then we get over here. After you harvest it, treat it, then you go to apply it. So, of course, now we have the application of the code. Now, with the application of the code, noticed we actually have more codes, but uh, then it starts saying, oh, autograph to wound and donor sites. So that's a game changer. So there's all of these components. one new area has implemented all of these new codes. One, two.
Yeah, it's the skin cell suspension that's new. And if you've done any grafts for the other type of grafts, it's the same pattern. It's just a new technique.
Right. So multiple codes there for a new technique that became its own. The baby code became an adult code. That lady in waiting is now, full-fledged.
Yep.
But all of these components is all about the one procedure that's being done. Okay. So now we're going to skip. Let's go to what's next. Arthroplasty. Now, I'm not going to go in section even for all of these. The reason I'm not is because you actually have access to these codes. And so we're teaching you and giving you the ability to say, oh, this is the highlights. What's applicable to you may not be pertinent and applicable to another person tonight. So therefore, I'm going to give you a highlight, and then you can go ahead and do more investigating on your own. So we got some one out here standalone arthroplasty, and notice it is a metacarpal joint. Metacarpals, hands, because you hold onto your steering wheel to drive a car, right? And so it's a uh, transfer of transplant tendon. So again, then we get into another little area that has to do with T-cell therapy. All of this stuff is pertinent because of emerging technology and things that they've learned. All right. That's why you're seeing these codes. All right. Let's jump into our fours. Now we're going to do some excision or destruction intra-abdominal, or all of which then it starts telling you what intra-abdominal is, primary or secondary tumors. So now we're going to excise, which means remove or destroy these tumors. What we didn't have before, I believe, if I remember right, is we couldn't do an excision or destruction open. There wasn't a code for that. They had it blown out into multiple codes. So this is where you start seeing codes deleted to make room for a more applicable, pertinent, practical code. So we're trying to make the code set easier. And then these are all based on size. Right, then we jump into our fives. Here we are getting into doing an ablation. Now, there's all kinds of ablations that can be done in the body. They can, most commonly, you probably heard of ablations, uterine ablations, where they laser, or they can use hot water and stuff. They do a lot of ablations of the heart when you have, like six sinus syndrome, or some type of an electrical issue going on in the heart. And they also do ablations in the brain. So again, there's different reasons that they do ablation, but this one is a ablation transducer for delivery of thermal ultrasound to prostate tissue. Now, again, this is a little standalone area. It makes sense. Every year for breast cancer and prostate cancer, probably two of the main cancers that get a lot of attention and money, funding, and research. So you will always, I don't think I've ever seen a year in the update since I've been doing it that there wasn't some new code that didn't have to do with an upgrade in treatment for prostate or breast cancer. So this time we got one. Then we did jump into some other procedures for the bladder, neck, and prostate. See, so again, we're getting a lot of updates in technology to be able to deliver some of these procedures. Now, I'm going to go ahead and jump into the sixes now. This is still an ablation, but this is thyroid tissue that they're doing. Now, is this the same as what they were doing at the prostate? No, it's a little different. Don't think that they're just doing ablations, but you can start seeing this theme now that we're going with. What's getting upgraded and improved? What procedures have been used with those temporary codes? Frequently, ablations. Ablations are working, and this is how you know that. So again, now we're into thyroid nodules. Now we go into ultrasound ultrasonic ablation. So this is one type of ablation, but now they're doing this like MRI guided high intensity ultrasound. Ultimately, it's stereotactic ablation. All this new technology, those temporary codes have grown up. All right, then we're going into uh, facial. It's not facial; it's facial.
Fascial.
Facile, yeah. I do tend to it's not potato. There really is a true way that's accepted, and I tend to torture a lot of these. The
You're right.
thoracic fascia, because I was saying facial one day, and then I said, "No, it's facile." And then again, yeah, fascia.
Well, think of myofascial
Yeah,
or
I call it my
myofascial release. That's talking about the wrapper on the muscle, the fascial muscle.
and I don't call it fascial, I call it facile, which is wrong. But that's it's like I said, you get it clicked in your head, and you can't break that thing in your little gray cells. All right, so now they're doing a block, and again, this is emerging treatments that we've been seeing being done. I know there's a lot of these blocks for pain that are game changers for people, and uh, it was just the other day we had somebody saying, "What code do we use for this?" Well, there isn't a code for it. Well, there is now, right? You got specificity. So this is all done in uh, we're talking about the back, and so we have laterality there. So if it says unilateral, it's one side, bilateral, both sides are being done. So that's the big thing here, right? Is the location, and then is it unilateral, bilateral, and also you've also got this infusion. So I think of this, it's not, but this is the way my brain works, is think of an epidural that's plugged in and it's still giving the medication to be able to relieve the pain. That's kind of what they're doing. They can do injection, or they can do like it's almost like an IV of pain relief in the back in these blocks.
A stick or a drip.
Stick or a drip. There you go. That's another, yeah. So now we get into a different area. We did thoracic. Now we're doing lower extremity. And then that ends right here. Notice that there's a trend. Once you get one code, then you have to do the unilateral, bilateral, and then, is it the stick or the drip? Right. Then we can move on to implantation of an iris prosthesis. Do you guys realize what that is? That's the eye. You know how everybody has different colored eyes. Now, there is a lot of different reasons why that has to be cut up and taken out and stuff. You've probably seen people that have had eye surgery, and they have, maybe they have a cat eye pupil or little nicks in their pupil. There's a particular genetic disorder where they're both end up looking like a cat eye, and that's just genetic, the way the eye developed. So for whatever reason that they're doing it, they can now go in and put a prosthetic iris in there. And this includes the suture fixation and the removal of the iris when performed. So I guess, if you want to think sci-fi, if you want a different color eye, they can do it. That's not why they would do this. But again, pretty cool, right? Uh, Now we jump into the sevens. Whenever we're dealing with the sevens, what do the sevens stand for? Does anybody know off the top of their head? Shout it out. I'll count to 3 and see if you can do it. 1, 2, 3. Imaging. Imaging is all the sevens. And so MR safety implant or foreign body assessment by blah, blah, blah. Uh, uh, let's see, skip down here. Analyzing current MR continuous status of individual components and systems, and consulting published professional guidance, blah, 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 and written report, initial 15 minutes. And then you're going to notice an additional 30 minutes. So what are they actually doing? They are uh, writing the studies for these MR imaging. All right. Now let's jump out of those, because that's all time based and so on and so forth. In the past, that stuff was all combo code in. They didn't get individual reimbursement for those. It was just part of it. And so now they're saying, hey, this is really, really complex for doing those reports and so on and so forth. We need compensation. All right. Jumping into 8 already. We're moving right along. Let's see. Cytogenomic genome wide. Okay, now we're getting genetics. So now we're looking for blood malignancies. And this is really, really interesting. Notice that this is optical genome mapping. Now, that doesn't mean it's you're mapping the person's eye. That means that they're actually using the provider is using their eyes and visualizing and doing the mapping process. Okay, so again, not as familiar with this, so I can't talk off the top of my head, but most likely they were not getting reimbursed for this additional work that's being done. If some of you guys are work in this area, maybe you want to give a shout out of how this may be applicable to you. I'm sure everybody will be interested. Not only are they being able to do this analysis, but now we can also jump ahead and look and identify specific bacteria. So now we've got one that's vaginosis and vaginitis, but this is a real-time PCR amplification of the DNA markers for blah, 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 all that fodder. Wow, right? And you think, well, what does it actually do? Well, they're coming up with the ability to, on the DNA level, to find out why these women are suffering from this. Identifying those bacteria, those organisms. So again, so cool. Transplantation medicine, allograft rejection kidney. Did you know? Little shout out if you guys didn't know, but when a person gets a kidney transplant, they don't like take out a kidney and put another kidney in. No, you keep your kidneys because even if they're working 5%, that's 5%. And you want 100%. So each kidney works 100%. And then whenever they have these procedures, like we talked before, it comes in stages. You have to have a team that harvests the donation kidney. You have to have a team that makes a pocket in the body for the new kidney because you're not taking a kidney out, you're literally adding a third kidney. And then you have a team that puts in the new kidney. Now that you know all of that, one of the problems that they have is that a patient can have rejection. And if they have rejection, we need to be able to track that and study that, so on and so forth. So this is where that comes in. So allograft, meaning from somebody else, not your own body, another human, rejection kidney, and then they're going to study the reasons why ultimately. And it's including or wait. Yeah, including subclinical rejection, so on and so forth. So that's pretty fascinating. I thought that was, if you study people with end-stage renal disease and the complications and what they have to go through to be able to get a new kidney. And also because they have this code now, they can maybe figure out why it rejects. Why is there maybe they can say, oh, now we know that they need this, or it lowers the rate of rejection again. Now we get into something I know very little about, is this the 8
Path
to
and lab.
yeah, path and lab. Uh, it's not that I don't want to say I don't know as much about it, but this isn't my world. But I can tell you that historically, working with people that are sitting for credentialing exams, path and lab is where most of them fail because it's an alien world to you unless you work in a clinical setting. Then it makes complete sense. So when I tell you I understand path and lab, what I don't understand is what this word means. I know what beta means, but again, I don't understand what the lab is for. So as you're
I always said that was the hardest section to teach coding because we can't relate to it. Like E&M, we're a patient. We know what it's like to have an office visit. Radiology, we've probably had some sort of x-ray. Like you can go through everything, but when it comes to lab, we don't know.
That's right. Right. So unless you
Not relatable.
were a person that worked in lab, or you drew blood, or you're a clinician that has to, see these orders come out all the time, again, that these additions and panels don't always make sense to lay people that are new to medicine. But what I can tell you, and we're going to go through this very quickly, is it is a new lab test. Simple as that, to identify something. Uh, neurofilament light chain, NFL. So what you can do seeing this is, if you don't know what that is or what they're checking for or what disease process it's related to, jump out and do some research, Google it, increase your knowledge base. Which I think this is, what do you think that's, you think that's pronounced tau?
Mm-hmm.
Yeah, okay. Uh, Now we get into something that we know a little bit more. This is strep, pneumonia. Pneumonia caused by strep. So they're checking that. But notice this word here too, just a little insight education. Quantitative versus qualitative, quantity versus quality. That is something when you are working in path and lab that you need to know for testing purposes. There is a difference in those two terms. And a lot of times, if you don't know, you look at it real fast, speed read it, and you don't realize that you've picked the wrong one. And we're still going on with just detecting different types of things that you can get through blood tests or other types of tests. Notice here we got a COVID-19 test, um, meningococcal. This isn't pneumonia, but it is the meningococcal virus. Oh, this is the vaccines. I'm sorry. Now we're moving into the vaccines. Again, every year you're going to see vaccines updated because they're different strands. So when you say that you're getting a meningitis shot or you're getting a flu shot here, this is a specific type. And every year they come out with a new one, and they have variants. They have specific things added to them. So that's what this is. Also, not on these. These are all intramuscular because most of the time this is RSV, the vaccine. Uh, Most of them are intramuscular, but you do have to look at some of these things that are injectable, the way they're injected. Are they IM or sub Q, so on and so forth. So pay attention to that. All right, we're going to get through those SARS and stuff. Look, we're almost to the end. Now we are going to jump out after this, and then we're going to look at some specifics I want you to be aware of. Here is some
We got
ophthalmic.
about 15 minutes, so
Okay.
just so you know.
All right.
Time check.
So let's see again. Nothing. Administration of RSV, again, injection. Notice that was intermuscular. Let's get to the here. Here, this is the end. This is where we're going to talk a little bit more about right here. Game changer. Heads up. This is applicable to everybody. If we didn't learn anything, well, we did. We learned a lot after COVID in the lockdown. But telehealth had been around for quite some time, but it wasn't being utilized or implemented to the highest level because it was new and there was really no reason, so on and so forth. And then we were forced to use it, and they were scrambling to catch up to make it more, not only more user friendly, but also to be able to track it and give proper reimbursement, right? So they just kind of made this umbrella of codes. Well, they're going to knock out those telehealth codes that you're so used to using. Now, telehealth is going to be a mirror to in-person visits, the regular E&M. So I'm thinking of, now we have E&M, outpatient, but now we have telehealth E&M as well. The beauty of this, though, is that they just mirrored it. If you know how to use E&M, this is a no-brainer. So let me highlight here, and then we'll talk about it just a little bit more. Synchronous is going to be on all of those. You got everything divided up. So there's multiple codes because they leveled out just like regular E&M. Audio, video, or you're going to have audio only, right? So you got those two divisions. It's going to be now new patient. We couldn't do that before.
Yeah.
I mean, is that a game changer? Well, Laureen and I were talking about the opportunities that this is going to be a big impact on the way we practice medicine. And a lot of those people that slip through the cracks and don't get proper treatment because they can't get in for whatever reason are now going to be able to have a visit to at least get established and so on. And then it's going to be really valuable to the provider because it's going to be a revenue for the hard work that they're going to put into this. So they're going to be able to reach more people. So that's the second thing is new and established patients. Then we've got it just like regular E&M, you get to pick. Do you want to go on medical decision making or do you want to go on time? So as it mirrors, straightforward, low, and then we go into moderate and high. Ta-ta, right? And then, or if it's better value, you can do time. Because again, you may have a straightforward visit on telehealth, and yet the patient's cognitively impaired or needs more of your time, so it may be, like I said, straightforward medical decision making, but you ended up spending 30 minutes with that patient because of those other reasons. So you can bill out the time. And this also includes the time getting ready for the call and the time after the call, right? So just like E&M. So now we have audio visit new, then we get audio visit established, same thing, divided, just mirrors, and then we get um, audio only, exact duplicate, just like E&M is 9920 and 9921. They mirror each other, and the same thing here. Brilliant. But what does that tell you? That means your template needs to have this new verbiage built in. You're going to have to identify audio or uh, visual. Also, new and established. We didn't have that with telehealth. The medical decision making and the time should all be built in to be captured. So those of you that are have that power to do that, and that ends there. So let's go ahead and go back here. Go back to my slideshow.
And for those that are asking about getting the recording after, because this is being simulcast to YouTube, LinkedIn, Facebook, those videos will stay up there so you can rewatch them there. And also, if you're a club member, you can get the video plus the handouts and some other goodies.
All the
access
other
to us.
Ask questions and pick our brains. So digital medicine, as you can see, digital medicine got a big focus because we consider telehealth a form of digital medicine. So 98975 was updated to include digital therapeutic intervention, and the code range 98976 through 78 were revised to include device supply for data access or data transmission to support the RTM for patient. Remote monitoring is what that is. So again, remote therapeutic monitoring RTM services were editorially revised in these codes. So heads up on that. Another thing in those codes, those O codes that we were looking at, not all of them meant the same thing. Oh, Vanessa makes a good point. Check with your payer. Each one can have different requirements. Excellent, excellent advice, you guys. We could tell you, hey, this is the way they said it's going to be done, but the payer is going to make their own decisions. And so, what you can't just say, well, CCO said. No, the payer gets to do whatever they want. This is the guide. This is the way it's set up, and then they can take the ball and do what they want it. But again, our main theme here with those O codes, not just with genetic, is artificial and augmented intelligence. It's the wave of it's not the wave of the future. It's here being used. And don't think that it's going to take your job. What it is it allows us to drive to a point and focus things that we can't see. We've done lectures already on AI, what it can do and what it can't do. So embrace it, because it's going to be able to find statistics that we can't grasp. So there's 7 category 3 codes have been established for AI augmented data analysis involved in electrocardiogram measurements. Huge. So AI is taking those echoes and being able to see things that they can't see visually. Medical chest imaging and image guided prostate biopsy. Always told you, prostate, breast cancer. Both of those are high on the level. So notice these codes end in a T, because they're the little temporary codes. And then maybe next year, if they're implemented and used a lot, we'll be talking about them as being used in the new codes. Yeah, when verify patient demographics can tell you more for using those treatments. Absolutely. Thanks, Jane. Oh, that was Jane Spitfire. Well, I recognize her. She's always on the webinars. General surgery.
I was teasing her because she said, "Is this AI?" I said, "No, we're real."
That's right. All right. General surgery, the sections to reflect the novel approaches of skin grafts. We already highlighted that for wound care and recovery. And then advancements in surgical techniques for the elimination of tumors within the abdomen. Remember, I highlighted those already. Those are the code ranges broken down. If that is applicable to where you work, where you can do a little more investigating. The E&M changes that we wrapped up with. Big game changer, guys. So say goodbye to 99441 through 99443. So we took those 3 little codes and they blew them up and added a whole new E&M system that makes us have the ability to treat our patients virtually now. And I think that this is probably going to be your main focus when you go back to work, and uh, you're going to educate your team on that, including your providers. That means you need to jump on those EMRs and get your templates set up so they're ready to go January 1st. Not only is this a added area of revenue for the providers, more importantly, this is going to help treat patients in your patient population that often get slip through the cracks. And so I truly think that we're going to see a big difference moving forward on the way medicine is practiced in the regular outpatient. But this also is going to cover a lot of other things. So I wanted to give a little shout out with 98016 because our providers are doing so much work virtually. So if you have a brief communication technology based, meaning they go into the portal predominantly, or they could text you too. Small minor changes in the description codes were also made for here. But now this 98016, I would focus on that. I would also get into my compliance notebook and come up with some protocols for using 98016, because I'm sure it's going to get looked at. But again, our providers are spending a lot of time in those. Did I go the wrong way? Oh, okay. Sorry. Spending a lot of time on those portals and they're not being reimbursed. Really quick, EPS changes will, because this is so straightforward, you can see how it's highlighted and what is the changes in each one of those areas. So
this is something that I had done, and it's just from teaching how to prepare for certification exams. Compare and contrast. What's the difference, so that you can do that to pick, codes out. But it also helps with comparing previous years to see what the difference is. I find changes are more dangerous, more tricky than a brand new code, or because you have to look at differences that you've already accepted the old way, and it could really change whether or not you could bill for that.
Yeah, I'm a color person too. Deleted codes, we're going to strip through those because, again, most of the time it's just baby codes that were upgraded. Grammar for these change codes, predominantly it was the semicolon. And this makes a difference in the BAT technique when you see the semicolon where you highlight. So again, that is pertinent. Again, these are codes that were just updated. Most of it's grammar. Active codes, just pay attention to some of those, and we'll just skim through those. Now let's get into the fun stuff as we wrap up at the end. The CCO has implemented a new course, the Qualified Patient Illness Navigator. This is based on the new code that came out in 2024, G0023. We had providers ask us, hey, can you do a lecture, educate us on this code? We're going to start implementing it. And once we started looking at it to prepare a proper education, we said, how are you actually going to use this? And we said, you realize that you need to prove that the people that you have doing this service, this G0023 service, have been educated. And believe you me, OIG is going to narrow all these codes that are new like that. They narrow in because they're usually abused. So we said, you don't need a lecture, you need to get your people certified in this. And so we developed a course, and it's pretty straightforward, it's fabulous, and it's again, don't let those patients slip through the cracks. It's kind of a cross between being a social worker and liaison for a patient, especially with new diagnoses and chronic conditions. And so 9 modules, I believe we came up with, predominantly developed for people like MAs. They're going to take on this additional hat, this new role, and it's also income for your clinic. And so again, they have patient illness navigators and courses, but it's usually always oncology. Now they've said, hey, we can let everybody do this now, all of your patients. A question, though, on category 2 codes, do I have to use modifier 25 on E&M codes like 99213, the for high blood pressure category 2?
Modifier 25 you'd use if the procedure has an inherent E&M component, history exam, medical decision making. You put the 25 on the EM to say, no, this is a separate E&M from what was baked into the procedure code. So that's the question you have to answer for that.
And feel free to check in with our CCO club. Great way to ask that question, and we can flesh it out and give you some examples. We'll be able to do that for you. That's
and in the free forum that you joined in order to be able to do the CEU, you can ask questions there too. We give priority to our club members, but normally other people in the free forum will answer each other's questions. So feel free to post there as well.
Other CCO news, Veterans Day sale ended, or is it still going? No, I guess it's good. Jesus got this all prepped for us. Intern program is open again. We have a great internship program. If you are wanting to knock the A off of your CPCA, or if you're just wanting to get more experience and work on some really amazing projects, know that we are education based. So we did have some interns say, oh, will I be doing coding and billing? No, that's not what we do. We're education based. And so the projects that we have are fabulous and exciting. Monthly webinars are always going to be the third Thursday at 8 p.m. Eastern. Starting January, yes. And we're giving you the free CEU. It's always going to be on StreamYard, and the replay will be able to go to the club members only, cco.us/club. And then, of course, you can view the live stream. The 2025 live medical coding review blitz, guys, is going to air live in December. We're going to take 2 Saturdays in December. We've done this before. It was fabulous, fun, interactive, and
actually, it's 2 Saturdays in January.
Oh, sorry. Okay, so now we're going to do it in January. Last time we talked about it, we were talking in December, but you know what? December is a really busy month.
Well, and it's also because we bubble and highlight the BAT technique for the new manual, which is being done right now by Chippy, who was one of the original students of mine that learned that method. And she's done it every year for me. So she has a broken finger. So she's trying to get it all bubbled and highlighted. She ships the book to me and I put that on camera when we do the blitz. So there's a bunch of steps that have to happen before we can do the blitz, but you'll be very prepared for 2025 if you're going to be taking your exam then.
That's right. All right. The CEU password. Do you want to take this, Laureen, and talk about that?
Yeah, I already pasted it to all the areas. So what when you registered, you were told, please register for the free forum where you're going to have the CEU quiz. If you haven't done that, then you're going to have to do it now. And that means you might have to wait till tomorrow morning to get your email getting you into that free forum. If you pre-did it, then go to that link. And it is, I'll say it one more time. It's cco.community/exams/316. I'm pasting it once more in the chat. And when you get there, you're going to click on exams, and then you'll see, just like this picture, the exams are the number one is that tab. And then number two, you click on the free CEU exam. And then number three, you're going to click on the one for the CPT update. And the password is coffee, COFFEE, all lowercase. And I think it's just one question that you have to answer, and then you'll get your certificate. So if you have any trouble, we do have a help desk. She'll be looking at that tomorrow. Don't panic if you didn't get something tonight. You can always email the help desk. We're going to help you do that.
24 hours. Yeah. Again, and most likely you won't have any trouble. However, if you do, we're here to walk you through it. But it's pretty straightforward, guys.
I did do a drawing. We have one winner, Karen Hawks. So Karen, if you're still in the audience, if you can email Sylvia at cco.us and tell her you're the winner, and she'll let you know what your choices are with courses or something from Find a Code. So Karen Hawks, you are the winner for tonight.
Now, as we wrap up, the very last thing that we want to tell you is as we said multiple times, education is our predominantly main theme at CCO. We are passionate about it and we do it well. But we need to hear from you. If there is something in the industry that you need to know more about, that you want us to unpack, that you want us to do the research on, or you're struggling with, let us know. Because as I always say, if you don't tell us, then you're going to hear a whole lot about ICD, because that's what I love to talk about, and the disease process. And I keep saying, Laureen, let's do another Pearl. Let's talk about this particular disease. And it's like, no. So again, let us know what you need so that we can be relevant and help you. The submit your topic request is a real easy, user-friendly way to do that. You go to cco.us/topic-request. There's a little form there that you can fill out. Give us as much information as you have. If you have some examples or something that you want us to look at, maybe say, oh, hey, can you give us examples of scenarios where telehealth and coding the new telehealth codes? Absolutely. Can you give us some examples of those new brief conversation code that I did in green? Yes, absolutely, we could do that. Or again, something similar in your practice that you're struggling with, or you have a question. And it doesn't just have to be about the codes. It could be compliance. It could be billing. It could be you want to know more about what provider patient illness navigators do, and how would I implement that in my practice, etc. Again, we're here to help you, and we take your suggestions seriously. A little shout out though to the CCO club members. If we know you're a club member, and we will know when you send in the topic request, you get priority, right? Mm-hmm. They get the most love from us.
Top of the line.
And that wraps us up, guys.
Thank you, Alicia. Good job. Well done.
We did it right on the 5 after. I can't believe we did that.
I was worried there. I was worried. That's where we're going, but
yeah, I get off on tangents.
All right. Well, thanks everyone. So hopefully we'll see you third Thursday in January for the next webinar. And then, or if you're going to be doing the Blitz, it's going to be the second and third Saturday of January. So hope to see you at one of those events.
All right, guys.
Bye-bye.
See you next time. Bye-bye.